better sleep, sharper focus, a healthier life. It all starts with how you breathe.
Welcome to the No One Told Me, the Airway Health Connection, the Untethered Way, where better breathing meets better living. I'm Dr. Maggie Graham.
I'm Dr. Liz Turner.
We're the co-founders of Untethered Airway Health Center,
on a mission to help you breathe freely and live fully through proactive airway health.
Whether you're a dentist expanding your airway expertise
or a family looking to sleep and breathe easier,
you're in the right place.
Each week, we'll bring you bold insights, real-world stories, and expert tips.
All to help you take control of your airway health. Because when you breathe better, you live better. Let's get started.
Hi, everybody. Welcome to No One Told Me, the Airway Health Connection. I'm Dr. Liz Turner, and we are here to continue to bridge the gap between airway dentistry and medicine. And today I have a very special guest and friend. Her name is Kimmy Herrera. Kimmy is a myofunctional therapist extraordinaire, and I'm going to go ahead and let her introduce herself.
Well, I love to hear that. No, I'm just kidding. I'm Kimmy Herrera. I'm a myofunctional therapist with a dental background, dental hygiene background. And yes, Dr. Liz and I are colleagues and friends, and it's been so fun in the last, gosh, how many years have we been doing this together? 7, 8 years or so.
It's been a minute.
Yeah, growing and learning together. And I feel like, our abilities together to continue to push ourselves to learn more and be better all the time and do better for our patients. And I think that's why we really click well. So my background is dental hygiene. I'm no longer practicing in dental hygiene, but I've been in dentistry for 25 years in all different areas of the office. But I hung up my scalers in 2020 to focus just on myofunctional therapy, which I started in 2017. And there just aren't enough hours in the day. I loved hygiene. I wanted to do both. I tried to do both, but you can only work so many hours.
I had that conversation with someone today. I said, time is the factor, because as you go deeper into this space, the more you realize that there's just a continued unraveling of the knot that is the puzzle of health. And myofunctional therapy, tongue tie releases, those are a huge part of it. But the way that you and I look at this, and this is why, like, you are really, really high level in the space, because you're always pushing the envelope when it comes to healing and opportunities. And so I think those are some of the things that we wanted to talk about today. So why don't we kind of just dive into those? First off, let's go into provider collaboration, because none of us can do this stuff in isolation. Like, how do you find that patients are finding you now? Because I think that's always a really interesting question. I'm sure the answer was different in 2017 than it is now. When you were starting this in 2017, you were kind of one of the OGs and the original few. So how did people find you? It was mainly through dental referrals, wouldn't you say?
Mostly, yeah. And I would say the majority was from the tongue release providers like yourself and a few of our
colleagues. I wasn't even here then. I was in Minnesota. So
a few of our colleagues.
So
kind of how it started was that I was really fortunate to connect well with some OG tongue release providers in our state. And we had our little study club that we've had going for a long time, our little TOTS study club in Colorado, which is great, multidisciplinary. But just that's kind of how it started. I was able to kind of get in, and then was getting just a ton of tongue release patients. And so I very quickly learned how to manage all of the post-op recovery and learned a lot about what's working, what's not, just always trying different things until I really hammered out my protocol with it. But that's really how it started. I was very fortunate because, like you said, there were only a few of us, and there was nowhere I could go to shadow, to learn. And so I had to do a lot of learning on my own and just really try to find those resources and find people globally, really, that I could connect with, which was great about, this day and age with virtual stuff, and found my way to a really well-known international study club group platform, Airway Circle, and was on the board of Airway Circle for a few years and really helped build a lot of those programs. And so that was a huge thing for me, was just learning constantly so I could always be my best and have anyone else to help me.
relationships in this space are everything, and not from just a referral standpoint, but from a learning standpoint. Like
Yeah,
we all see certain cases certain ways, and collaboration is so key. So,
totally.
I mean, nowadays, like we used to think tongue and lip ties were just related to feeding or the concept that it's speech related as well. Like it's all there, but now we're seeing more and more adult patients, and you manage a lot of that. So,
Mhm.
can you speak a little bit about how myofunctional therapy is beneficial pre and post things like MARPE, MMA, like these complex adults? It's just so many more layers to the onion than children. And when we talk about that, traditional orthodontics versus what they're going through, there's probably some details that others could be missing. Do you want to talk about that a little bit?
Yeah, I would love to. Thank you. The standard like training in so many things is standard and basic and introductory, myofunctional therapy or airway dentistry, tethered oral tissue, all of these things, you can get a baseline training and education, but you really have to continue to push through applying the critical thinking that we're establishing along the way as we see these patients and recognize that there's more than that. And
Hmm.
so when we talk about like our tongue release patients, myofunctional therapy is a huge piece to that. Of course, we know that. I mean, you talk about this all the time. And but there's so much more that myofunctional therapy needs to be a part of as a supportive thing. And so really what I try to explain to patients is especially in collaboration with structural changes. So when we talk about MARPE and skeletal expansion, or we're talking about MMA surgery, joint replacements, all these more in-depth airway treatments, the structure is changing, but we know that the function and the structure have to work together. They have to complement each other. So if somebody is changing their structure, their skeletal airway, but never addressing the functional airway from a soft tissue management perspective and mobility and oral rest posture and compensations, all of those things are left untreated, we're only addressing half of the puzzle. And while the skeletal has to change, just has to, right, in order to get our optimal results, but we can't ignore the functional side either. And so, what I've seen over the years and what I've kind of trialed and errored too is we used to say myofunctional therapy comes after expansion.
Hmm.
And what I've really finessed with patients is how beneficial it is before, during, and after their expansion. So, especially through those skeletal changes, and the function may start to develop new compensations as the structure changes. So, we can't ignore the fact that we have to work functionally at the same time. And then we're also able to really help them reduce like tension patterns. And I'm talking not just myofunctional therapy, but from a manual body support perspective too. Is the structure is changing, we have to make sure that we are not getting locked up on one side or the other because of tension patterns or the rotations in those craniofacial bones, really having their manual provider to help unlock them as they're changing, as well as the functional changes too. I find much more symmetrical results, more balance from just a whole body perspective. And then by the time they're done, they have reached that kind of like ideal platform now of their forever habits and function and breathing and sleep and all that.
Well, it's incremental training, right? It's not just trying to oh, let's just wait to do everything at the end, because there's such a learning curve. And you
Yeah,
could almost argue that there's then three phases towards the myofunctional therapy versus like just pre and post tongue release. Like
exactly.
it's the original anatomy, and then it's the change in the skeletal anatomy. If there's a tongue tie release in there, there's a whole nother phase too, because each phase of this is a new normal. And
For
I'll
sure.
say when I had my MARPE removed, like I felt a lot of, and I'm not a big feeler. I'm hypermobile, but not in the traditional like EDS sense.
Yeah.
I felt a lot of instability in my head. Like everything just felt like off because that. And then for me to retrain my tongue to live in the right spot, even as a grown up who thinks about this stuff a lot, it took a minute. And
Yeah.
I mean, it's still a work in progress. There's nowhere near the tone that there should be. So, but in kids, like, how would you manage someone in an expander? Like in an ideal world, what would you like to see us as orthodontists or tie release providers doing to best serve our patients and you guys from the myofunctional side? Like, what would be your protocol?
I would say, the release providers are definitely doing the right thing at sending patients for myofunctional therapy first. And then once the myofunctional therapist has established everything that can be established, get them ready for a really good functional frenuloplasty and then all the posts. So I feel like for the most part, the release providers who are practicing at a high level like you understand that and won't do a release until they've been sort of cleared for it from a functional standpoint, which is great. From an ortho standpoint, I think if those patients can get referred early, that's ideal. So, I recognize just from being in dentistry so long, I understand the flow of the office. And I recognize that like an orthodontist has a patient comes in, or ortho provider does all of the records, and like the patient's ready. Of course, they want to start. Most patients going into an ortho provider are like, they want to get going. So you want to use that momentum, of course. Don't stop and say you have to go do myo first and then come back to me. But there's a process of lab fabrication and all the things of designing what's the appropriate appliance for that patient and their expansion protocol. There's a whole time frame that they could be starting their myo and then during that time. I love seeing a patient for a myo assessment, at least an assessment before their case is fully designed from the ortho side, because I feel like I can add to the conversation and share with the provider where I see some functional limitations from a structural barrier. And so if I'm able to share that with them and say, hey, we're having a really hard time with the tongue fitting in the palate, I think, they need more room. Are you able to achieve XYZ? And then that will give them the structure to support the function. So I think that collaborative conversation from the beginning of treatment planning is really valuable. That's ideal. Obviously, not all patients are going to work that way for different reasons, right? And it's always about meeting the patients where they are. But from an optimal, ideal perspective, we can see them before and treatment plan somewhat together in the sense of, the functional input, at least, right? I'm not going to dictate the ortho treatment design, but I can just add to the conversation of like, we definitely need more tongue space. Do what you can do to create more skeletal space. Or we're talking about nasal breathing difficulties and all the nasal airway patency screening that I do in the assessment. I'm able to then say, hey, this is kind of an argument. Let's say the patient is a pediatric, they're kind of right on that cusp of like RPE or TAD based expander, which route are we going to go? If I'm doing nasal airway patency screening and I'm finding that there's some structural concerns from nasal breathing, I feel like that tips the scale to go more TAD-based bone-borne expansion to give them that broadening through the floor of their nose and help increase their nasal airway. And that might have been the deciding factor on which design the doctor chose.
Yeah, and I mean, I've run into that before where parents come in and they're trying to really weed through their options. And based on being able to do an assessment prior to them coming in for the release, because a lot of times, especially if they're coming from someone like you, it's like you send a report. I know what your thought process is, and I know the progress that's been made and the time that's been rendered. And so a lot of them are trying to decide between tongue tie release, ENT, orthodontics. But then they're quick to want to do the release. And I say, you know what? Like this is the cherry on top of everything. Myofunctional therapy is where the magic happens. So don't even rush this tongue tie release thing. Like they're like, well, we want to get the expander in 3 weeks. I'm like, well, there's not time for the contraction phase and the remodeling of the tissue for you guys to have a good result. So the chance that you're going to need a second stage is high. And would you argue the same thing for MMA patients? Like the new normal and the movement of the skeleton is going to bring the fascial planes into different directions. Again, I have a dear friend who's a dentist who's been through two tongue tie releases. First one, less than ideal, but either way, went through orthognathic surgery and then needed more myofunctional therapy and a second stage. I think that's a conversation that we should be having with people just realistically, so they don't think that there was, something wrong the first time
Yeah,
or what could we have done differently. It's almost like you just got to see what happens once things are moved.
totally. And with that, depending on all the logistics of their surgery, whether they had um depending on like where incisions were made and what type of advancements are they involving the chin, Is the surgeon doing anything sublingually?
Mhm.
That can also impact tongue mobility post-op from their surgery. So I've had cases where we had enough room in the mouth to safely do a tongue release prior to their MMA, which I
Or
have
they're trying to avoid MMA, and it's a step in the continuum that they're willing to go through
right.
safely. Because,
Yeah.
I mean, I think there's a lot of those cases that we're going to continue to see. Because a lot of
Mhm.
times, don't you think the tongue tie release and the myofunctional therapy, it's like the first step in their breathing journey, and they're trying to avoid bigger stuff. But I think in the pipeline, over the next couple of years, we're going to see repeat patients coming back being like, I'm finally ready. So, but
Oh, I mean, we've seen it. Like I have patients come back 3, 4, 5 years later, and they ask me, "Okay, I'm ready to take my orthodontic journey, or I'm ready to consult with the surgeon." When we talked about it before, most people can't do all the things we say from day one. It is our job in our comprehensive assessments to talk about all these different puzzle pieces for them, and then ultimately they have to make an educated and informed decision. But it doesn't always happen right away. Very rarely do I could count on one hand how many patients I've had probably who have been like, okay, great. Who's my surgeon? Great. I'm ready, 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 ready. It's like that's that's not practical.
yep. And normally they've already been through a number of other providers before they land you because otherwise they
Yeah,
wouldn't know.
right.
So,
Exactly. So
uh,
most people are having to process this and take it one step at a time. And the easiest thing to do is start with myofunctional therapy
sure.
because it's not invasive. They're able to work it into their regular day. Nothing changes from their, schedules. They're not having to take time off. This is not like it's not debilitating. It works right into their schedule. And then they get some momentum. And I find that they start feeling a difference. They start becoming more in tune and aware, and they start paying more attention to how they're breathing and how they're using their orofacial muscle complex. And they start connecting on a level they had never connected before. And then that motivates them to like take the next step in their journey as they
Mhm.
start feeling a little bit better. And then usually if they have enough space, the tongue release is the next easiest, quickest thing to do. Recovery
Sure.
on that is, even though they're still, their body is reorganizing and restructuring for a long time, but the more immediate healing in that,
Yes. A
6 to 8
week.
weeks
Yeah.
post-op, where they're having to do more intense exercises and such. But it's really pretty short on the grand scheme of
Yes.
the
And
whole
it's
treatment.
not like orthodontic surgery where you can't eat, you're wired shut, you have to be somewhere across the country, all these different things. And
Yeah.
then each layer of this brings another element of risk. So like you said with
Yeah.
myofunctional therapy, it's minimally invasive, it's completely reversible, and for those patients, it can give such an incredible proof of concept
Yeah.
and a layer of trust, right? Like
Yeah.
your patients come back to you with such a level of trust because they're like, Kimmy, you were right. Like
Mm-hmm.
this
Yeah.
was a problem for me. You could see it right away. I just took some time to have to process that information as a patient. So, yeah,
Yeah.
it is really interesting. I mean, a lot of times I say I quarterback a lot of care. I think from the myofunctional therapists really are the ones that quarterback a lot of it. And that's the benefit of working with someone like you is you really understand the limitations of the skeleton. So, I think that's kind of my next question. Like at times we do have to meet patients where they are in less than ideal scenarios. Like we
Yeah.
can't force somebody to go and change their skeleton. It's
No.
expensive. It's time consuming. It's uncomfortable. I've got a million other things going on in my life, says the patient.
Right.
But so we do have to make concessions from ideal.
Yes.
Or is the answer no? I can't help you. Like, don't you think it's better to help
Mm.
someone in some respect, even if
Absolutely.
you can't do all the things?
Yeah, and just being upfront with them. I mean, I know that a lot of myofunctional therapy introductory courses teach their attendees and students that myofunctional therapy can fix everything. While I'm so biased, I would love to say that that's true, but it's just not, because it's only like that's the functional side of the puzzle, and
Yeah.
there's a whole skeletal piece. But what I tell patients is that ultimately it's about trying to make something fit in their life within their means and resources, and something's better than nothing. And if somebody's able to do just myofunctional therapy but they can't take on the other things, at least not yet, we're still getting improvement and working towards our goals, right? And we may not have this, like, our ceiling maybe here, um versus up here if we were able to do everything. But that can still progress over time. And I tell them it's not all or nothing right in the beginning. And we maybe start here and then they come back in a year or two or three, whatever, and they're ready for their ortho or they're ready for, and I always, when I finish with them, is I give them that guidance to say, look, in an optimal structure, in theory, you shouldn't have to continue your myofunctional therapy after you've established habits. But another thing that I've evolved over the years with is I actually do strongly feel like people should maintain exercises long term forever.
They're
And it's
skeletal
like,
muscles, like
it's
they need
another muscle in the
maintenance.
body,
Hmm.
right? And so,
Hmm.
yeah, there are things that necessarily aren't actively working, like tongue posture. We've established a habit, right? And when we get to the end of their therapy journey, their tongue feels awful to have it rest on the floor of their mouth. When I have them try it, it's so unnatural and uncomfortable. Like that's not something they would necessarily have to continue to work on,
Hmm.
but continually working on their oral pharynx and oral pharyngeal muscles and their nasal breathing support and facial balance, and staying in tune with themselves on um, functional chewing and swallowing and symmetry. Like there's so many things that they should continue to support, especially in our hypermobile patients, because
Absolutely.
of the collapsibility of their airway is greater
Hmm.
because of the elasticity or that laxity in their muscle and soft tissue structure, and joint support. There's a lot of things that we still have them do that I've ruffled some feathers over the years when I've said that to colleagues, but that's just what I'm finding. And why wouldn't we? Why wouldn't we want to support good muscle health the same way we do for our whole bodies?
For sure. And what patient hasn't heard that in relation to their whole body? Like,
Exactly.
glute strength, grip strength, all these things are indicators of long-term health, but they require continuous work. I was
Yes.
actually filming the complications module for our course today, and one of the sections is on establishing realistic expectations. One of the biggest risk factors I find, I would say one of the big three, the other being pain, tight healing, and then inability to cure all of your symptoms. Because I think so often people come in with this expectation of this will cure my sleep apnea. It will also fix my pelvic floor and my shoulder tension and this, and I'll be able to articulate and swallow pills with no problem. And I'm like, whoa, let's hold
Uh-huh.
on. I expect improvements in all of those spaces.
Hmm.
Will it cure all of your problems? No. Is it a complete magic
Never
wand?
promised
No.
that.
So
Yeah.
it's establishing expectations. I mean, I see it a lot in the baby space too. Like my baby is still clicking, and it's like, well, that's because the strength is actually better than it was. But the
Mhm.
problem is that your child has a very vaulted palate,
Yeah.
and with this, we're optimizing growth. But we can't control it the same way we can orthodontically. And same thing with tonsil and adenoids. Like a lot of them come in, they're like, we did the tongue tie release to prevent the need for tonsil and adenoid surgery. And it's like, well, we can't control the fact that our environment is gunky and that there's mold in a lot of our homes and X, Y, and Z. So, I mean, and that's where the conversation on hypermobility comes in because you and I both, I'm extremely fascinated with it. I know you are too.
Yeah.
And I think my fascination really comes to a few patients where I was like, what an outlier in healing. Like, why does it look this way? Why is it so granulated over? Why does this person on paper have such incredible range of motion yet have more symptoms than anybody I've seen tied to the tip? And I mean, what are your thoughts on hypermobility?
Yeah. I mean, oh, I love this topic. Like you, just super fascinated. I have some slight hypermobility in my tissue like you, but I'm not, from a joint instability standpoint, that's not an issue for
Yeah,
me.
I'm the stiff hypermobile and the like have to rest on everything. And I'm like,
Yeah, the leaning.
yeah,
Yeah, yeah.
yeah,
And so oftentimes patients come in, see you or me or people who are speaking in this hypermobility space and bringing awareness to it. Obviously, within my scope, I can't diagnose hypermobility, but I can screen for it, I can educate, and I can point them to the providers who can.
yeah. My
And
main statement is 1 in 4 patients has some form of hypermobility connective tissue.
yeah,
I can't tell you what you have. I have a suspicion based on your tissue texture, and this is why we manage surgical healing across
yeah.
the board this way. So,
Yeah, totally. And, when I'm doing the functional assessment, like you see, is these patients are having on paper this incredible range of motion, this incredible mobility that, they can perform. So when
mhm.
you're asking, to open wide, you're taking their comfortable mouth opening, or you have them lift to the spot and you're suctioning, all the things they can stretch. And if you just watch them, place their tongue there instead of just like waiting for it to get there and measure, like actually watch the process. And you can see that it's like the tissue goes and then it goes some more. And it's that extra that they can give on command, but it doesn't have any relationship with their oral rest and what's happening at rest. And so it's the rest that's the problem. It's not how far can they reach when you ask them to. And so, really doing that floor of the mouth hold and watching the mobility there where we can kind of take out some of the compensation with the floor of the mouth elevating up and that extra stretch in the tissue. That is a big game changer for patients to feel their restriction because they can actually recognize like, oh, I can't actually lift my tongue when you have your finger in there. That's a huge thing. Plus the jaw, right? Like I know the second they open their mouth, I'm like, all right, you're measuring off the end of my ruler. This is not normal. Let's tone it down. We need to help them understand where their range is and try
Yeah,
to
just
stay
because you
within the
can
range.
doesn't mean you should.
Exactly. And helping them, connect with the body professionals who are speaking the hypermobility language. We both we have our favorite gal in Colorado we send to for all that, but the support of just recognizing that the patient needs educated too on how they use their body. And so many times they've always thought that it was this or that, or I always wondered why I could do that and nobody else could. And, they're doing all the things with their fingers and it's like they feel validated all of a sudden and they feel like, okay, like this is okay. I'm not like a weirdo here,
And
but
don't you think so many it's the first time they've heard it? Like,
yes.
yeah. It's
Yeah.
becoming
And
more awareness towards, but
yeah,
it's just such a challenge. And I think the hard part too is like orthodontically, I don't think that they present with some of the same early stages of crowding and things like that quite as much as others. So it's like they're almost more likely to get missed. It's just a
totally.
very narrow arch form, but because of a tongue thrust and those compensations, they're lifting enough to move things into the visual alignment, but not
Right.
really truly the skeletal proper alignment. So it just
Exactly.
seems like so many of these cases are never bad enough on paper for anybody to ask questions because they're so good at compensating. But then that cascade just continues. I would say so many of our patients are 30 to 45-year-old hypermobile women.
Yeah.
And it's because like the pelvic floor stuff, the jaw stuff, the orthodontic shifting stuff, and just I think almost like being dismissed for so long and starting to do their own research.
Yeah. And then, we're giving them that voice to be able to advocate for themselves and feel heard. And then they're empowered and then they move forward, because they recognize there are options for me and there is a team that will hear me. And another thing you mentioned with the hypermobility and wound healing and how these people may respond differently. And so being proactive in understanding the potential of hypermobility for them is really valuable for us to be able to help them through their wound healing protocol and being able to use products like serapeptase and maximize stretches and use their capabilities to their benefit. And throughout their whole time in myofunctional therapy, we have to recognize too that they may not be able to do the exercises exactly the way we're prescribing them. And we have to use other ways of supporting their body. Sometimes that's laying on the floor while they do their exercises because they feel like when they're pulling that fascia and they're getting that pull from the occipital area that they're just like kind of how you described when your marpy came out, like they feel off. They may have increased vertigo. They may feel like something is getting rocked and it's unstable. So we use hard surface sometimes to like rest their body against, give them some support. The more proprioception they have helps them recognize where they are in space. And if that means using their fingers just along their mandible, right? They're not guiding and doing it with their fingers, but they're just that little touch and support
Tactile.
is super powerful for them. And just the jaw, we have to recognize too that just because, like you said, just because they can go there, we shouldn't go there. We're gonna hurt them more than we help them if we do that. And so recognizing where's our healthy range for them and help them stop there, using bite blocks to stabilize the jaw, whatever we can do to give them more proprioception, tactile support, I find is really helpful that they're able to connect a little bit more. And then they're not overdoing it, and then they're doing enough.
Yeah. And
Yeah.
isn't it interesting how it can all change the timeline, right? So often people come and they're like, so when should I schedule the release? And I say, whoa, whoa, whoa. Like we have to see how you progress myofunctional therapy. They're like, well, don't you need to like send notes? Don't you need to? And I go, based on, I gave you a little sheet, says structurally what you have. The most important thing is where you are functionally. Like,
Mm.
I don't actually care when or if you schedule the release ever, because there are probably some of these cases where they start myofunctional therapy and they're so unstable that moving forward with a release may not be the best thing. Like, not
Exactly.
everybody needs a tongue tie release.
Right.
And at times, if we're just kind of like blanket statement, like, oh, you have a tongue tie, you should get it fixed, that's not really the right answer. It's like, oh, you have a functional problem. Let's see if we can cure it with
Yeah.
myofunctional therapy, or if
Yeah.
maybe we trigger something that then leads to another step in the puzzle, MARPE,
Right.
orthognathic surgery. Like, a lot of these patients have degenerating joints and they're
Yeah.
completely unaware.
Yeah.
You can see a functional shift. And you can hear they're like, oh, it used to pop and now it just sounds like popcorn. And I go, whew, like, we need a lot of stability that I don't know if we can gain with this
Yeah.
alone. So that's the hard part, is delivering some bad news sometimes.
I know. And you touched on this like shift, and there's also this whole asymmetry factor that as a myofunctional therapist, I'm a huge like educator on this, like with my colleagues to say like CBCTs are so valuable, not only from like what the doc is using it for and the airway and treatment planning, but from a myo standpoint, we're actually able to use the CBCT to tailor our exercises, help patients get through their myo faster because we can really target more specialized, tailored exercises for their needs. So if I have somebody and I see facial asymmetry, I need to figure out, is that skeletal, muscular, or both? And so I can do all the muscle testing and determine, okay, well, yeah, they can use one side, they can do this, they can't do this. I can figure some of those things out from the functional assessment, but is there a whole skeletal component to this? Are they canted? Do they have a yaw rotation? Are they, what's happening skeletally that's also impacting their appearance? And I could work muscles all day long, but if it's a skeletal problem, we need to know that so we can be fair in our expectations with the patient. If they're saying they want their this to look better or that to look better, we have to be really looking at it globally from structure and function,
And
and helping them achieve those goals is huge.
And a lot of this I think if you are a new myofunctional therapist or new to airway dentistry, like, this can sound really intimidating, right? Because it's like, wait, yeah, I don't know if I learned that in
Yeah.
that course I took.
Yeah.
So it doesn't have to be, though. It's more about kind of looking at each case individually and saying, what's different than standard in this situation?
Mhm.
And that's where, like, you have a study club.
Yes.
And it's for Colorado,
Mhm.
correct?
Yeah, Colorado myofunctional
Mhm.
therapists of all
Mhm.
backgrounds.
And what was your intent with creating this?
So my I've been wanting to do this for a long time. I started it this year in 2025. And my goal is to bring all of our local Colorado myofunctional therapists together so that we can support each other, have a safe space for learning without so much vulnerability. It's always vulnerable, right? If you feel like you're subpar from someone else, but trying to squash that. So I'm creating this environment where we can all come together. We all have different backgrounds, we have different years of experience, right? But none of that matters. So we're coming together and learning together and creating a standard of care because everybody's learning in different ways, different courses, different instructors. They were taught by other people. So whether they come from a speech background or a dental hygiene background, right? You can have some variations in what you're taught, but it's so powerful when we can come together and we can merge those two. And then we're able to lift each other up and we can challenge each other, raise the bar. And then I see that trickle to our collaborating providers are now having to raise their bar because all of a sudden now all the myofunctional therapists are saying the same thing. And there's a standard. And now we're going to hold the providers to that standard as well so that we can collaborate and give those patients their optimal treatment plan and results. But if one myofunctional therapist is saying never checking nasal breathing, and then another person is only talking about tongue ties, and somebody has a surgical case, they've never done one before, like how do we find this common ground where we're all practicing at a higher level? So that's where that comes from. And I'm excited. We've had 2 meetings so far. It's been so fun. And so far I'm the only one presenting, but I'm hoping that like people will want to present on things too as it gets going. And but it's been great, really supportive. And it's a mix. We've majority dental hygiene, but a good amount of speech language pathology background, which I love. And we've had some body professionals in there, and it's great.
It's important. I mean, it's important for us to keep elevating our skills because we know more. So it's kind of like
Mhm.
we stay back with the information that we were using in 2017, 2020. Like, we're
Mhm.
never going to get any better and we're never going to have better outcomes. And I think as this space is under scrutiny, and even the myofunctional profession, just from a standardization standpoint, it's really important that you're doing something like that. And kind of like dentistry and private practice, like a lot of us are alone on an island, and it's no different for myofunctional therapists that are kind of starting out on their own private practice. Like you said, there can be some fear of putting yourself out there of like, wait, am I supposed to know that? And it's like, no,
You're
actually,
right.
no. Like
Yeah.
you've been doing this for what, 9 years now. It's something that it takes practice and it takes patience and it takes experience for to be able to look for those things. But if somebody highlights it once, like the chance that you're going to open someone's eyes is so, it's having such a big trickle down impact. So I'm really
Mhm.
excited for you.
Thanks.
Day. So I mean, coming from myofunctional therapy, like if you were starting over, what do you wish you could have had access to? Is it this higher kind of level of understanding and education, like a mentor where, you had some, but not all that many because just the
Yeah.
sheer numbers of providers was so low. What do you
Yeah.
think you could give advice to people that are kind of just starting out in this space?
I would say, to recognize that one introductory course is not enough, to continue taking courses. And that was part of what like drove me to be part of a team that was creating more advanced courses. And that was sort of a, a goal to sort of be the person that I wanted to have to go to. And so, trying to, and I actually would say to other more experienced providers, is be that person too. So there's the advice to the newbies is like find your person who you can go to. But you have to just jump in. You have to. And I think that a lot of times us professionals, all of us in this like healthcare space, we want to be good, right? Like we don't pour so much of our lives into something, countless hours and trainings and money and time, all these things that we do behind the scenes that patients obviously don't see. That doesn't come just for fun.
No.
Like, right? Like you do that because you want to keep being your best. So we have this innate desire to be that. And so I'd say, like, don't let that fizzle out. Like, keep pushing, but you don't have to take these big, expensive courses over and over. Like, you can learn so much from a lot of webinars that are out there now. I learned a ton from webinars, and connecting with someone who can help you is
Yeah.
huge.
Relationships.
Yeah, great relationships, like a mentor. And then those who are seasoned, I say be the person that you wanted that wasn't available to you at the time. Like pay this forward. I
Totally.
think I think sometimes people get hung up in like, well, I didn't have anyone to go to. I had to figure it out so they can figure it out. It's like,
Yeah,
how
I
is
don't want
that
to give away
helping the
my
field?
information. It's like,
Yeah,
well,
that's
you're
not helping.
no,
It's
it
not
doesn't
helping
help.
the field. It's
There's
not helping the
plenty of
patients.
patients to go around. Like, let's
So many.
just, yeah.
And that's the other thing is like the more this becomes standard of care,
Hmm.
the more patients will be educated from their referring providers, right? So we've got to get out there and continue to like help people learn this, because that's the only way that it will keep this. Myofunctional therapy has grown exponentially in Colorado since I started. The first study club meeting we had, I had no idea what to expect, right? And I blasted it out on all these platforms or whatever. And there were 40 people there on the first meeting. And
Crazy.
I was like,
Crazy.
oh my gosh, I didn't know there were so many of us. And there were still several people who couldn't make it. They're in um, the Western Slope or whatever, a little too far out of the Denver metro area. But I was just like, this is incredible. And yet my business has grown every year, even though there's more myofunctional therapists. There is no threat, you guys. Like,
No.
spread the love, spread the knowledge, encourage each other, and keep people going, because it hurts me when I see people burn out or they feel like it's too hard, right? It's too hard to build relationships. Like, no, no, no. Find your person to like be your cheerleader.
Yeah.
Call me. I don't care where you are, but like, I will help you connect with someone I know near you. I don't know, but
Well, yeah, you're
um,
passionate about educating, and like as your practice has grown, you've had to do that because you can't do it all alone. And I mean, that's what I found in teaching, and that's why I launched these two courses is because like, I have knowledge that I want to share to people in a systematic way. It's like
mhm.
there's always these kind of like drive-by conversations that I can help with, but if you don't look at the knowledge and the information comprehensively, sometimes you can miss stuff. And so, I
Yeah.
mean, that's the beauty of having kind of a study club setting is you can have somebody presenting, you can have a follow-up to have conversations about like, hey, I had a question about what we went over last time. And so I'm
Yeah.
just so excited for you. And we can link, do you guys have a link for it or?
Yep. I can send you that.
Okay,
Mhm.
yeah, I can link that in the show notes. And who knows, maybe it'll be more than Colorado one day, but
Yeah.
not that you have the time for that. But
I mean,
I'm
I've
sure there are
mentored
people
on
listening that are in other places that would love something like that.
I mean, I loved when I spent time, doing that on the global scale, and it was
Yeah, with Airway
amazing. And
Circle.
I love
Hmm.
that. Yeah. And I'm able to right now focus my time on our amazing little local community, which
For
is
sure.
great. Like in Colorado, we have so many forward-thinking providers like you,
Yeah,
and
we're really
we have
lucky.
options.
Mhm.
And is it perfect? No.
But
But
does
it's,
everybody have? I mean, some states like there's not even a person, and we
yeah.
have, like you said, 40 myofunctional therapists. Like we have a number of release providers that are kind of holding high standards. So we are
Yes.
really, really lucky and privileged.
Yeah.
And I mean, even from a patient perspective, like it gives credibility when people are on the same page. Like I have a number
Mhm.
of providers that I say, you know what? I feel like you need a second opinion because what I'm saying to you just isn't resonating. But if you're going to get a second opinion, I would highly encourage you go to one of these three people because
Mhm.
I don't want you to be completely dismissed in your concerns.
Yes.
And that's what I've seen happen.
Yeah.
So it's really nice to have sounding boards and people with similar philosophies, and not everybody's as lucky as us for that. So,
I know.
and that's
Yeah.
kind of the impetus
True.
for this podcast too, is like, how can we spread this information in a really
Yeah.
positive way? So,
Yeah.
oh, Kimmy, it's such a joy to work with you. It's been so fun to kind of see things evolve for
Yeah.
you and the growth of your practice. Kimmy delivers Palisade peaches to all of
Yeah.
us once a year, and everybody looks forward to them. And
It's my like, yeah, it's my little
once you
like
even met me
fingerprint.
in my driveway, you're like, I'm in the neighborhood. I was like, I'm here. So,
Yes. And then the kids were like in the basket, like, oh, feet,
oh
oh,
my
feet.
gosh, I'm like, don't touch my things. I was
These
touching
are
everything.
mommy's.
These are mine.
Yeah.
So, well, you are just such a gem. I can't tell you how grateful I am for you doing this, taking the time out of your schedule. I know you have to go see a patient today too, because you always are. But Kimmy has a couple of locations locally and then a couple of other therapists that she works with. She also does virtual. I can link her practice information here. And Kimmy, is there anything else that you'd like to share with everyone?
Just, I think like we touched on so many little things that I feel like we could get deeper in, all these things. And it's more of just like trying to bring awareness that like this is so much more. And hopefully that's motivating people to continue to keep learning and collaborate with other providers, who are talking about these things like we are. Um, I'm always here. It doesn't have to be Colorado. I get messages from people all the time from all over saying, I'm looking for someone for this or for that. And I have colleagues all over the place that I
Yep.
can connect with and say, like, hey, I've got this patient who needs you, or do you know who they can see for blah, blah, blah. And so,
We'll have to connect on that too. We're building out a provider locator because we
oh,
manage a lot of the
yes.
same thing. And it's just
Yeah.
hard. It's patients across the world that are
Uh-huh.
looking for support.
Yeah.
So many questions from the UK. Like if you're in the
Yes.
UK and you want your dentist to learn this, you need to give them the tools to do it. Like make
Yeah.
them take the courses and listen to the podcast.
Yes.
But
Yeah.
tongue up, lip sealed, breathing through the nose, proper swallow pattern, like the big four.
Yeah.
But the trickle down of that is so much greater. So it's kind of
Right.
looking at the details and dialing in all of it.
Yeah. And I would add a big five with compensations.
First, yeah.
Is like, removing those compensations or at least reducing based on how much the patient's able to do from a full body perspective,
Yeah,
right?
even from the MMA, like the compensations that come from that scar tissue, I've blasted a bunch of scar tissue out on people with the laser to just kind of
Yes.
give them more range of motion. It really helps. So,
Yeah, for
all right, my
sure.
dear. Well, thank you so much, Kimmy Herrera,
Thank you for
incredible
having me.
provider. I will link all of her information here, and we can always do a round two.
I'd love that.
Thanks for tuning in to the Untethered Airway podcast.
If today's episode helped you see things differently,
Please share it with someone who would benefit from hearing this. And don't forget to subscribe.
want to learn more about airway health or connect with our team?
Please visit our website, untetheredairwayhealthcenter.com, or follow us on Instagram @untetheredairway.
Until next time, bye.